Hello, everyone. My name is Nicole Duritz, and I am with the Medical Society Consortium on Climate and Health. And I guess why don't we go ahead and get started? I do want to let folks know that this webinar is being recorded, and we will post the full webinar as well as the slides and other resources as quickly as we can following this session. So I would like to welcome everybody to our webinar, From Concern to Action, Health Professionals Leading the Charge for Extreme Health Protection. If we can go to the next slide. So just a few housekeeping items. Again, if everyone, we will keep you muted throughout this session. Again, as I mentioned, the session will be recorded, and you could submit your questions using the question and answer feature, and we encourage you to do so. If we go ahead to the next slide. We are very excited that we've had the opportunity to work in coalition with some of the leading health organizations to bring the voices of health professionals to this important discussion on the impact of extreme heat on health in our communities. And again, I am very, very excited that we have a wonderful expert panel that is joining us. If we can go to the next slide. I am not going to spend a great deal of time, or any time actually, discussing the amazing bios. We sent that out in our invitation, and we're happy to share everybody's bios with you. But I would like to go ahead and jump in and talk a little bit about why we're here today. And we can go to the next slide. We know through extensive research that when nurses and doctors and other health professionals talk about the impact of climate on their patients in their communities, it really does impact and influence decision makers. And so we are gathered here today because we know that your voices are needed in order to make sure that when OSHA finalizes its standard for heat protection for workers, your voices need to be heard. We know that industry's voices will be heard loud and clear. And so we need the health voice to get out there so that we can make sure that the best standard is adopted and implemented. And with that, I would like to go ahead and turn it over to our first speaker. We are very excited to have Dr. Ruth Madura-Leamy here, who is going to talk about the impact of extreme heat on personal health, on our communities, and on our health system as a whole. So let me turn it over to Ruth.
Thank you so much, Nicole, and thank you everyone for taking the time to be here to discuss this important topic. I am Ruth McDermott-Levy. I am a professor at Villanova University College of Nursing, and I'm also the co-director of the Mid-Atlantic Center for Children's Health and the Environment, which is a pediatric environmental health specialty unit. And in addition to that, I'm a member of the Alliance of Nurses for Healthy Environments, and I serve on their steering committee. The next slide, please. So heat is our greatest cause for extreme weather mortality. And you can see from these data that we have had increased heat deaths over the past 3 years from the data that we have from the CDC. And older people are at the greatest risk for heat-related death, but certainly we're going to get into occupational risks as well. Our agricultural industry is at risk of heat-related death, but they're also at risk of other deaths. And this is the only data that I could find related to an agricultural industry. And so it's both heat-related and injury and other exposures. But it's 19.5 deaths out of 100,000. So you can see that this is a high-risk occupation. Next slide, please. When we think about heat and exposure to human beings, we think of what's known as heat-related illness. And there's kind of 3 classifications, but it really is thinking about kind of level exposure and level of impact on the human body. And so early on, you get things like muscle cramps and sweating. And then as you move into heat exhaustion, you get, much more many more symptoms related to heat exposure. And what we want to avoid is heat stroke, because that is a medical emergency and that does lead to a greater level of mortality. And so those of us that practice clinically really need to be attuned and aware to what is happening with the individual, and what sort of exposures, what they do for work, what things may be causing heat-related illness. Next slide, please. In addition to what we see during the day, when people are exposed to heat during the night, and also thinking, I'm going to get into some of the environmental justice issues, but people that are in substandard housing or people that may not be able to afford air conditioning, in some areas it does not cool down at night. And so we see this primarily in urban settings with urban heat island effect, but we can also see it in agricultural or rural areas where there is low housing, poor quality housing that may not have the insulation to keep people cool or air conditioning. And so during the nighttime, there's disruption in sleep, and our body does not go through the healing cycles to be able to cool down. We are seeing more research in this area, but there was a large Japanese study to demonstrate that heat played a major role in mortality. And of course, this was especially true for older people, but we do need to worry about our occupations that are spending a lot of time in the heat and then may come home to a place that is not cool for them. Next slide, please. When we talk about environmental issues and climate and health issues, we often isolate things and just think about just heat or just wildfires, but truly they often happen together. And especially this happens with heat. So with heat, we get poor air quality, so we can get high level of ground level ozone and particulate matter. So that can be problematic for people with cardiovascular disease or respiratory disease. Actually, ozone can be problematic for even healthy people. And then we can also get extreme weather events. And so I always remember Dr. Michael Mann saying, hot air holds moisture. And so when we have areas of extreme heat, and especially certain areas of the country that we see it a lot on the East Coast, where we get large downpours of rain and we get flooding. And so that can complicate things in addition to people having heat problems. And then in some areas, the Pacific Northwest is a bad example, I guess, or of wildfires where it gets really dry because of the heat. And so we have poor air quality and all those other risks that go along with wildfires. And then, of course, we can also have loss of energy. So that can affect communication and access to care. So heat is happening, it's problematic, but then there's these other things that are happening, and often simultaneously. So, we need to really think about the whole system and how it's impacted. Next slide, please. There was an op-ed recently in the New York Times written by Dr. Anthony Fauci, and he described his experience being diagnosed with West Nile virus. And initially they thought it was COVID-19, and it took them quite a long time to figure out it was actually West Nile virus. And so this is a really good example of what we're experiencing with climate change and the heat impacts, that we need to think again more broadly and not go with what our typical examples are and what we typically expect. And if Dr. Fauci took a while for them to figure out what was going on, we are really being called to really practice excellent clinical skills. So with heat, of course, then we have more vector-borne diseases, as I said, more extreme weather and flooding. This can affect people's shelter. And so we can have people who, at one time had homes and may not have access to their homes. We see more mold and fungal illnesses. And in my role with the PACU, I do know that healthcare providers are not up to speed on how to manage these. So we need to learn more about that and know what to expect. We see problems with food security. We can also see loss of employment and then mental health, and from stress all the way to PTSD, and then also, of course, exacerbation of existing mental health problems. So again, heat is a problem, but it often amplifies other issues as well. Next slide. When we think about vulnerable groups, especially when we're thinking about occupational risk, every person on this list is susceptible. We do have pregnant people working in the agricultural setting. We often have children who are working. Of course, outdoor workers are people who work in an environment without air conditioning, older adults, as I said earlier, and then people with pre-existing or comorbidities, people with substance use disorders, and they may be in the workplace, and then people with disabilities. The only person or group that would not be included but can be impacted indirectly would be infants. And so really, because infants then may be exposed to their parents or caregivers, bringing home, different chemical exposures, but also them not being well and, having issues with loss of caregiver. So all these groups are vulnerable when it comes to heat. Next slide. Those people who have non-communicable disease or chronic disease often rely on medications, and there are medications that make people sensitive to heat or more sensitive to heat. And so the list is here. We see it with our antihypertensives, we see it with diuretics, and also some antipsychotic medications. You will have access to these slides, and you can link onto the CDC clinical guidance for more information. Time doesn't permit for me to go into all of these, but it is really important when you're prescribing or educating patients about medications, which medications require special instruction related to heat. The other thing to be aware of is that many medications, especially oral medications, lose their efficacy in heat. And so the range or recommended range for medications is from about 59 to 85 degrees Fahrenheit. And again, thinking about people who live in homes or bring their medications to work that are not in an air conditioned or a cool setting, their medications may not even be effective. So that needs to be included in any patient education. Next slide, please. So my favorite breakfast, and I had it this morning, is yogurt, blueberries, and nuts. And when I have that breakfast, I'm constantly reminded that that didn't just show up at the grocery store. These products that I'm eating, the yogurt relied on a dairy farmer, the blueberries relied on someone to grow and pick the blueberries, and the walnuts required somebody to harvest them. And so most of those groups are experiencing these social factors and enable us all to be able to have healthy food to eat. They tend to be low income, tend to have low educational attainment. Often communities of color or immigrant and marginalized groups may have low English proficiency, typically in substandard housing, so they don't get that nighttime cooling that we all need. And then they also may be experiencing homelessness. And, again, we need to reflect on, we benefit from their sacrifices, essentially. So next slide. This is a wonderful reminder. So when you're starting to think about PSAs and things, this was on my package of cherry tomatoes. It is a produce company that put little bios about the farm workers. And so you pull the tab off and you can open up that tab and read the story about the work that they do and the families that they have. And so this is a reminder of the people that are doing the work that we need to look out for and take care of. Next slide, please. So that brings us to environmental justice. And I'm sure most of you have heard of this term of people that are of low income, often people of color, that have a disproportional burden of environmental hazards. And certainly our agricultural workers do, in the form of heat, but also, as I said, from exposures possibly to chemicals such as pesticides or heavy machinery. And we see the same thing with construction workers, that they're exposed to heat and heavy machinery, and also perhaps chemicals, but also poor air quality. Next slide, please. But those who are living with those burdens typically are disproportionately the people that produce fewer greenhouse gases, certainly in their personal lives. And so again, we need to think about our responsibility, especially as healthcare providers, to this population. Next slide, please. And so thinking about, what the vulnerabilities are related to heat and the population that we're going to be discussing as far as policy, we definitely need to be aware that they often are the group that have pre-existing conditions or comorbidities. They also have other challenges that they may not be able to remove themselves from the situation. Often they may have, if they may have air conditioning, they may not be able to afford to run it or choose not to for the cost. They may not be able to change their environment because of the other social conditions that I mentioned. And they may also have limited access to healthcare, and probably or may have problems with immigration status and language barriers. And so, they don't have the opportunity to move as easily as we do. Next slide, please. So that brings us then to our role as healthcare providers. And so what we typically see as far as admission of patients into the system, whether it be at the clinic or at the hospital, we are seeing increased heat-related illnesses and renal diseases. Heat can make people really cranky. And so we can have increases in intimate partner violence and conflict. Motor vehicle injuries are increased during heat. Again, people are kind of short fused and not thinking as clearly, more stress and anxiety. And then we're also having healthcare providers with limited experience in addressing heat-related illnesses. I'm on the public health group within my community, and we surveyed our healthcare providers, and they have not had additional training or education related to climate change and health. And this is actually a fairly affluent group of people that would have access to that. And so, those of you who are on the webinar, make sure you share this information with others. And then we're also seeing with our agricultural group, language and cultural barriers, and that affects the trust of between the healthcare provider and the patient. And so that can be an issue. Next slide, please. So for the administrators or people, in the leadership roles within institutions, again, there's increased clinic visits and also increased use of the ED. And I spend half my time actually in a rural community. And what we're finding is that people are going to the ED as a cooling center because, again, we need to educate the community of what to do to manage the heat. They also are having a loss of power for essential equipment and, relying on generators and things, and that can be problematic. And then disruption in goods that can occur because of the extreme weather and extreme heat. Also, I think it's really important that we remember, and I think we can, those of us on the webinar can all say, yeah, that it affects staffing. When these things occur, it's not just the people out there. So staff are stressed by this too, and their own families may be struggling. And so that needs to be addressed, on the administrative end. Next slide, please. So what can we do? It's terrific that you're all here and we're going to hear about how we can engage in policy. There's other things that we need to do also related to policy. Certainly address the heat, especially for our outdoor workers or people who don't work in air-conditioned settings. We also need seamless access to our electronic medical records across all health systems. I know that's a big ask, but we need to be able to collect this data and it needs to be accurate, and that's one way to do it. So we need to add that to our list of policy asks. Many rental units, depending on the state, require that rental units have air conditioning. That tends to be in our southern states. We need to start looking at that for states a little further north because we're all experiencing heat, not hate. And then also those of us who code for, put the ICD-10 codes down for our diagnosis of patients, there are codes for environmental and social conditions, and we need to use those, not just the medical diagnosis, because again, we need to collect accurate data so we can address these issues. Um, PSR Pennsylvania, Physicians for Social Responsibility in Pennsylvania, has developed a climate change assessment tool with the ICD-10 codes that go along with each thing. And it addresses, again, the medical diagnosis and those social and environmental conditions. And so I encourage you to look at that and rely on that tool. As I said, we need more continuing education related to heat-related illness and acute kidney injury. And then also, as providers, we need to include prevention and response to clinical encounters related to heat. And so, every opportunity we can discuss with the patients or whatever group you're working with, what they can do to prevent heat-related illness. And then also promote PSAs, including to heat-related illness. I don't know how many of us, I mean, we all go to a provider. When I sit and in the waiting room, I have these TV screens with all kinds of health information. Tends to be the pharmaceutical company trying to sell me something. Why don't we have PSAs in the waiting room about heat for the people? And then also prioritize our G communities and consider the influence of heat on patient symptoms. Don't just think about what their medical diagnosis is. Think about that example of Dr. Fauci. Next slide. So thank you very much, and I will look for questions in the chat. Juanita.
Actually, before Juanita begins, I just wanted to say thank you so much to Ruth. And also, just to let folks know, you can there are a number of questions, great questions in the Q&A. Feel free to add answers or share resources you might have in the chat segment. And also, I would like to invite all of our participants, if you'd like to introduce yourself in the chat, tell us who you are, where you're joining us from, what organization you represent. That would be great. So let me now turn this over to Juanita Constable, who is an amazing expert coming to us from the Natural Resources Defense Council, who will talk more specifically about the OSHA rulemaking process. Juanita, let me turn it over to you.
Thank you so much, Nicole, and thanks, Ruth, for that great introduction to the issues that we face. I'm Juanita Constable. I work for the Natural Resources Defense Council in the Environmental Health Department, and I've been working on occupational heat since 2018. So as you might imagine, I am super excited about this moment, and particularly to talk to you today about how you can use your expertise and experience to make sure that workers have the strongest, most effective heat protections possible. Next slide, please. So right now, most workers in the US are not formally protected by heat. Only 6 states have some kind of heat standard, but they vary a lot in who they cover. So for example, Oregon and Maryland cover most indoor and outdoor workers. Colorado, it's just agricultural workers. And a handful of cities also have ordinances, including Phoenix, Arizona. But Texas and Florida actually made it illegal recently for cities to set their own ordinance. They say instead that the federal government should be making these kinds of decisions. Of course, we don't have a federal standard, so that's a bit of a disingenuous argument, but that may soon change. Next slide, please. So in 2020, or this summer, in July 2024, the Occupational Safety and Health Administration, also known as OSHA, issued its first ever proposed heat standard. This would apply across the country, cover about 36 million workers, and the agency estimates that there would be about $9 billion in annual benefits just from avoided deaths and illnesses alone. I should point out that in terms of a benefit estimate, this is probably on the low side because OSHA didn't try to monetize things like turnover for employers that don't protect their workers from heat, or medical costs for workers that are not fully or covered by workers' comp at all. Next slide, please. So this proposal is frankly long overdue. Doctors have known for a really long time that workers and heat don't really mix. This is a quote from 1895 from a Boston medical journal. This doctor was a clinician and a lecturer at Harvard, and he wrote, "The dangers arising from heat prostration affect most particularly that portion of the community which is obliged to work at all times, irrespective of weather, and in exposed situations." So again, Boston, not a terribly hot place, but even then, it was a recognized threat. Next, please. This is just an animation, perfect. So then in can you go back one, please? And back, perfect. In 1972, OSHA's sister agency, the National Institute of Occupational Safety and Health, as one of its very first recommendations, suggested to OSHA that we needed a federal heat standard. Next slide, please. Now, OSHA's proposal is what's called a programmatic standard, not prescriptive. That means that they're not telling every single employer that they have to do exactly X when exactly Y happens. Rather, employers must evaluate their own workplaces and then implement appropriate controls for their context. In other words, compliance with the rule is going to look a lot different if you're in a sweet potato farm in Virginia versus a pizza kitchen in New York City. Next slide, please. Now, having said all that, there are still several requirements that employers will have to follow. They will have to have a written heat illness and injury prevention plan that is shaped with the input of their own workers, so the folks that are actually doing the work. They will have to provide clean drinking water at no cost to employees. I have heard some terrible stories about workers being forced to drink out of dirty coolers or being required to pay for the pleasure of hydrating themselves on the job. Workers will have to get paid rest breaks in cool or shaded areas. And I just want to reinforce that this heat is a problem for indoor and outdoor workers. And it's not always just the places that don't have air conditioning, because you can have an employer that has air conditioning in the offices for the administrators, but not necessarily the folks on the factory floor or kitchen floor. Workers will also be given a time to get used to working in the heat. That's called acclimatization. That'll be for new workers and workers that are returning from a long absence. And then workers will also be required to be trained on everything from emergency response procedures to their rights under this rule, and exercising those rights without retaliation from employers. Next slide, please. So the federal law that created the Occupational Safety and Health Administration significantly limited its power. Congress fought long and hard over this rule, and the result was that there's actually a pretty narrow slice in some ways of who OSHA can regulate. So they can cover most private sector workers, although there are plenty of exceptions. They can cover the US Postal Service, and they're allowed to inspect most other federal agencies, but not actually give them a fine. They do not cover self-employed workers, the immediate family of farm employers, workers exposed to hazards covered by other agencies, including mining, or state and local government workers. Now, there are states that have gone through the hoops to get what's called a federally approved state plan. Cal OSHA is sort of the most famous of the state OSHAs. And they're allowed to extend federal protections to state and local government workers. But there's a huge set of states in the center of the country and in the southeast that are very hot, where those workers will not be covered by this heat standard. Next slide, please. Some of the other proposed exemptions from the heat standard that I thought that I would raise for this group are sedentary indoor workers. So folks that are sitting or doing light duty work, even if it's really hot, will not be covered. Firefighting organizations, and then emergency medical services if lives are on the line and they're busy doing that work of saving lives. Next slide, please. Right now, OSHA's proposal is out for public comment until December 30th. And they want to hear from you, they want to hear from me, they want to hear from everybody. As part of that comment, they have specific requests for evidence. They're looking for additional evidence to support what they're already proposing, or contrary evidence to suggest they should be thinking about this in a different way. This is required by federal law and various interpretations by the courts over the years. So they're required to provide substantial evidence that their proposal addresses a hazard that carries a significant risk of serious harm specifically for workers. So although any person with a body is susceptible to heat illness, they specifically want to know about the occupational setting. They also need to show that their proposal contains reasonably necessary or appropriate actions that would reduce risk, and importantly, is technologically and economically feasible. As you might imagine, this last bullet kind of counteracts the one above it, or potentially counteracts it. And so there's a bit of a tension between making it the best standard possible, the most protective standard possible, and the most feasible standard possible. Next slide, please. So you, as health professionals of all stripes, are a valuable source of evidence. And when I say evidence here, I'm not talking about a court case or some kind of clinical trial. I'm not even talking about peer-reviewed journals. The fact of the matter is, most day-to-day experiences of workers, especially the kinds of marginalized workers that Ruth was talking about, don't show up in the peer-reviewed literature. And OSHA needs a full picture of what's happening. So you can provide evidence that supports what's already in the proposal or what needs to change, with everything from relevant studies to what you're seeing in your own patients or the clients that you serve. I also want to pick up on something Ruth said about staffing. You yourselves are workers, and it's entirely possible, depending on the environment in which you work, that you will be subjected, or your employer might be subjected to this heat standard. So you also have an important voice in that regard. Next slide, please. Now, there are 3 broad categories of ways to comment. You're going to get a whole list of resources after this webinar, and you can pick and choose. But I wanted to quickly go over some of the pros and cons. I am an advocate, so it's sort of my job. The easiest thing for you to do would be to click on an action alert that says, yes, OSHA, I support the standard. You could edit it if you wanted, but if you didn't, you could be done in a few seconds and go on your day. That's great. Those numbers are important. But if you wanted to go up a notch, you could join a sign-on letter. This is a little bit of extra work, especially if you're trying to sign on for your organization or for your employer. It usually requires a little bit of review, or maybe a lot of review, depending on your place of employment. But these letters are an important source of consensus from particular stakeholders. Now, there's no reason not to sign all the action alerts and all the letters that are coming your way. As long as they don't disagree with each other, I give you adult permission to go wild, sign them all. But if you have that kind of time, I'd also urge you to consider writing your own comment. And there's a few reasons why. If you and 1,000 of your friends submit your own individual comments, that will count as 1,001 comments. If you and 1,000 of your friends sign a sign-on letter, that will count as 1 comment. Now, this is not technically a vote or a popularity contest, but I can tell you that decision makers in OSHA and other important decision-making bodies like Congress pay attention to those kinds of numbers. Furthermore, if you write your own comment, you can go beyond the consensus in a sign-on letter, share more personal details, share individual stories of workers that you've talked to, or perhaps raise some additional research that comes in after the sign-on letter goes out the door. Next slide, please. So in terms of the timeline of what will happen next, OSHA is a very slow agency. They're a very cautious agency, and they have good reason for that. Partly, they have a lot of hurdles that have been imposed by Congress and by previous presidents. They get sued a lot, so they're very concerned about making things as legally defensible as possible. And they're a very small and understaffed agency. And whoever's in charge at the top obviously makes a very big difference in what OSHA prioritizes. So we expect that next year will be one last opportunity for public engagement through public hearings. Obviously, that will be another chance if you don't get to comment before December 30th, but those numbers will be limited just by the logistics of the hearing. So I'd urge you to still comment now, even if you want to testify. And then 2 years after that, or maybe 5, or maybe 10, depending on what happens, we'll see a final rule. This all means that the efforts to get state and local standards underway is still critically important, because workers can't wait for protections for this very long OSHA timeline. One last slide for me, please. So that is it for me. I do want to take a second, though, to thank all my local and state and federal labor partners and worker center partners. I mean, the whole workforce spectrum. They've been generous beyond measure with their time, with their energy. A lot of what you're seeing in the slideshow comes from them. And despite my big green credentials as being part of an environmental group, they've never questioned my desire to join their fight for better working conditions. I hope that you'll join us too. Thank you so much.
Thank you so much, Juanita. Oops. Thank you so much, Juanita. And before you step away, can I ask you to come back really quickly? We did
Yes.
have one question, which I think you might want to address right here, that talks about the impacts for on size of employer. And I know that was an issue that we had discussed. So when you have smaller employers, and how do we address that? So let me just turn that back to you before we turn it over to Brett.
Yeah, that's a great question. One of the biggest exemptions for small employer, very small employers, and for this I mean folks that have fewer than 10 employees, will be that they aren't currently required to have a written heat action plan. I personally think that that's a mistake, because if it's just up here, then your workers don't know what to do if there's an emergency, and it's much harder for OSHA to enforce if they, get a site or coming to do an inspection. However, I do understand that there's that whole feasibility analysis that OSHA has to do. That's the main exception. I would note, however, that in the annual appropriations, so the annual funding discussions for OSHA, Congress almost always puts a rider in that prevents OSHA from enforcing whatever rule they've adopted on farms that have fewer than 10 employees. So that really limits their reach for farms that perhaps rely on, again, marginalized workers. Does that answer the question?
Oops, sorry. Thank you so much. That is helpful. And if there are more questions regarding that specific issue, please go ahead and continue to use the Q&A function. We really appreciate that. And now I'd like to turn it over to Dr. Brett Perkinson, who's joining us. He is a practicing physician associated with PSR in Texas. And we are very excited. He's going to talk a lot about the relationship and what he's seeing in his practice, and also give even more detail on OSHA and the work that we are all trying to do right now. So let me turn it over to you, Brett. Thank you so much.
Yeah, you're very welcome. Thanks so much for the invitation to be part of this presentation. My background is I've completed residencies in both family medicine and occupational environmental medicine. So I feel like I've got a good perspective from the primary care physician as well as from the occupational perspective. And glad to share those perspectives with you. I've been in both public and private settings in the course of my career. I'm going to recap a little bit about what Juanita said regarding the OSHA rulings. And one of the things she'd mentioned that this really does go way back in history, but even more recently when the Supreme Court ruled that OSHA can define a significant risk. Really for the last 5 years, it's been slowly gathering information, gathering data, trying to put together a proposal that has a reasonable chance of passing in Congress. And from that estimate, this proposal is estimated to reduce heat-related illnesses up to 96% and fatalities up to 100% if it's enforced. Next slide. So I'm going to go into details on just a few of the points of the OSHA heat stress standard that haven't been previously mentioned, and then we'll talk a little bit about how you as a physician can make an impact in your testimonial or your letters. Next slide. The next 2 slides are just simply disclosures that this is free of commercial bias. Next slide. Next slide. So I mentioned the 96 degrees incidence rate, 96% of fatalities occurred when the heat index was 80 or higher. So that is a recurrent theme in the OSHA standard, is that the initial trigger of when an action item is done is when it's 80 degrees Fahrenheit, where most of the rules take effect. And then a high heat trigger of 90 degrees where additional rules take effect. And there's a reason for that, is that this is based on studies that showed that these fatalities, that if you look, 72% of all fatalities occurred at temperatures of 95 degrees or higher. And then if you go down to 80 degrees, you'll see almost all of fatalities occurred at these temperatures. So OSHA's trying to not inflict a bunch of standards in situations where there's very little chance of heat fatalities. This is all very evidence-based and unfortunately based on our prior history of fatalities. Next slide. So the OSHA standards is really divided into 8 primary steps of what a heat stress program should encompass. And Juanita has touched on some of those previously, but one is to designate someone as a safety coordinator at the site. 2, monitor temperatures, and that includes a wet bulb globe temperature, which is really an accurate way of measuring heat. Providing water and rest, shaded areas, acclimatization, which was mentioned previously, modifying work if you achieve these action triggers, training your staff, providing staff, and then monitoring for signs and symptoms of heat stress, and finally having a plan for heat shock and really kind of advanced heat stress symptoms about where you'll take the worker and people that are trained in the treatment for them. Next slide. If we go into a little bit of more detail, is that they must designate a safety coordinator to develop, implement, and manage the program. And this really is a complicated matter. So one of the issues why companies are pushing back on these heat stress standards is that they're concerned that it would affect productivity. And that is a legitimate concern. There's certain temperatures you really, if you follow the strict guidelines, no one can hardly work at all. So you have to do some modifications in order to make this accomplished. And so this person really needs to be at the grassroots level, but you actually need to have people in the C-suite on the corporate level that are making decisions that are emphasized. This has to be a written plan at each job site. You have to have good input from the workers that are actually experiencing the heat input. And then if you should have a heat injury that occurs at the site, or it's an OSHA recordable, then you need to reevaluate what went wrong, what can you do better. All of this is sort of the plan to quality assurance cycle that really any company needs to have implemented in quality assurance. Next slide. So the other thing is monitoring temperatures that I mentioned. So 80 degrees is the initial trigger and 90 degrees is a high heat trigger. This has to be a specific location because it's going to vary according to how close to the ocean you are. What is the radiant heat? What is the breeze that it flows through a particular area? So it needs to be a local monitoring program that's actively monitored. You can't just use a local weather channel and say that's the temperature for monitoring. Next slide. And if we lay out those 8 steps that I mentioned, you can see that each one of these different areas here, and we don't have time to go into detail for all of them, but each one of those triggers successively more action items so that when you look at this high heat trigger, you have to have, that's when these rest breaks stop, a minimum of 15 minutes every 2 hours. That has to take place. And so they're saying that it's not every temperature, you're not constantly having rest breaks, but you need to have these rest breaks on the higher temperature situations. You also need to have a buddy system. So one of the issues with heat stress is that oftentimes workers aren't aware that they're having mild heat stress symptoms. They're to develop a little bit of confusion and nausea, a little dizziness. But they're not really aware that they're being affected. And that's where a buddy system comes into play, where you have somebody else that's watching out for you. And if you're starting to see errors or problems or someone that's having some confusion, they can alert them, alert the others in the area, the safety coordinators in the area, and have an intervention. And then posting a hazard alert. Workers need to be aware that when these temperature situations are reached, either in a green, yellow, red, and black conditions are typically proposed, and the workers are aware so that they're aware to take more rest breaks during this time. Next slide. So in the summary is really on this standard here is that we would ask you to understand the new proposed standards, some of the different aspects of it, and knowing that if this passes, that compliancy is important. It's part of OSHA's plans for doing this, and then spreading your knowledge. And so spreading your knowledge, a lot of this is managerial issues, and you may not encounter this in the clinic. But where your strength comes in is that personal stories that you have as a clinician seeing patients with mild heat stress symptoms, with mild nausea, coming in with muscle aches, and really doing that additional part of the history to saying, could this possibly be related to mild heat stress symptoms that might otherwise be missed? We can capture the heat fatalities, but heat illness is often missed, and it's very underdiagnosed, and that's where you come into play. And so your testimonial of situations that you had with patients that came in with heat stress, maybe through the urgent care room, or maybe they came to see you as a follow-up from an emergency room visit. All those are important to tell, and it really gives a lot of strength to having the passage of this OSHA standard. And then lastly, the other aspect of it, again, is the reason why we don't have a heat standard yet is that corporations, businesses are worried about a decrease in productivity. And so that's where also your testimonial comes into play, where did your patient lose work because of this? Did they develop a chronic illness because of this? Perhaps kidney damage, as has been mentioned previously. Oftentimes when somebody has had severe heat illness, their perspiratory system loses its ability to perspire, and they are much more susceptible to future heat stress incidences. If you have a patient like that they were in effect either had to change jobs or on disability because of that, that gives a strong argument to some of those other forces, in addition to the healthcare and perspective, is to the financial aspect of this, is that this needs to be in place, and in the long run will help these businesses out maintain a more healthy workforce. So I hope that this has helped. Next slide. I've included a number of references that can help outline some of the work that I've done with others regarding medical surveillance and heat stress monitoring, as well as some great websites to learn more about signs and symptoms of occupational heat illness. And we'd be glad to take any questions. Thank you.
Thank you so much, Brett. So what I wanted to talk about next is action opportunities, as we have been discussing. So as has been mentioned, there are individual action alerts, and we have a number of coalition partners who all have their own individual action alerts. And again, as Juanita said, feel free to sign on to to use and participate in all of them. And if you have time to do that, we would love it if you'd write your own message also. For those of you who are joining us and representing health organizations, also in our resource guide, you will find our organizational sign-on letter. We have a bunch of different resources to help you share this information. We ask you as individual to reach out to your colleagues to share this opportunity and these opportunities. And if you are working within a health organization, please reach out to your leadership, make them aware of these opportunities. We have a sharing resource kit for organizations to use also. And we will be posting all of this information. Again, that QR code is going to take you to a toolkit, which we will be updating as soon as we are have completed this webinar. We will make a few little edits just to clean it up a bit, and then we will be posting that. And our colleagues in various organizations will also be posting their alerts and resources. We are so excited that we had so many people join. There have been active questions going through the question and answer, and we are going to try to get to as many of those as possible. And I would love to turn it over to our panelists to see in the last remaining minutes if we want to jump in and answer a couple questions. I noticed that there were a number of comments about the upcoming election, and I shared in the chat and also in the Q&A a link to civic engagement opportunities on our website. Again, we do know that sadly, health professionals who live incredibly crazy and busy lives vote at I think it's about a 20 to 24% lower rate than the average, the general public. So we have some resources to help encourage health workers and health professionals to get out to the polls. So we shared that civic resource. And then let me just turn it over to the other panelists to see if there were questions that you wanted to jump on. I see, Juanita, there was a question, a Texas question. Do you want to jump in and respond to that? And then Ruth, I saw that you came off of mute, so let me turn to you after Juanita.
Yeah, there were actually a couple Texas questions. I answered one live, but let me just bring it up since it's of concern. Federal OSHA is responsible for enforcing federal occupational health and safety laws in Texas. So while Texas and Florida have both prevented local governments from setting their own heat ordinances, they can't tell the feds what to do. And so once the federal standard is finalized, presuming our democracy still works the way it should, federal OSHA will be in charge of that.
Excellent. Thank you so much. And again, that toolkit that I just mentioned, in addition to the QR code, we have shared the link in the chat. Ruth, you would come off mute. Is there a specific question you'd like to answer?
I did answer in the chat for requests, but someone did ask about connecting with PSR Pennsylvania. They're from California. I put my email in. If you email me, I will connect you to PSR Pennsylvania.
Excellent. And Ruth also shared the link to the ICD-10 codes and that toolkit. So we will also, you can see that both, I think, in the answers and in the chat. And we will make sure that that resource is also shared. So again, thank you for those questions. I'm sitting here also trying, as I'm doing this live, scanning if there's other questions, folks. There are a lot of great resources that have been added into the question and answers. Again, if folks have time and can, if you're asking about what our organizations are, I am with the Medical Society Consortium on Climate and Health. Ruth is with Annie. Ruth, do you want to just introduce a little bit about Annie really quickly, and then we'll turn it to Juanita and Brett.
Sure. Annie is an international organization. It stands for Alliance of Nurses for Healthy Environments. And so we address environmental issues. And Sarah's on too. I know that it's primarily nurses, but I also know we have others who are not nurses that participate with Annie. So, and we have a lot of resources related to climate and health as well.
Thank you so much. And Juanita, do you want to just give a quick update on NRDC?
Sure. NRDC is one of the larger environmental groups in the US. We are headquartered in New York, but I'm based in DC. And we work on pretty much every issue under the sun, it feels like, but we have a lot of environmental health scientists on staff, and climate and health is a major priority for us. Thanks.
Excellent. And Brett?
Yeah, so I'd mentioned I'm with the University of Texas School of Public Health, but I'm also within the school a member of the National Institute of Occupational Safety and Health, or NIOSH, Educational Research Center. And there are ERC, and there's a number of these ERCs across the country, and they really serve as referral sources for anything to do with occupational or environmental exposures or health risks. And so we have people that do air and water quality monitoring, just a variety of different backgrounds, and provide both education, research, and training to groups. So it's glad to have the opportunity to be here.
Thank you so much. And again, I mentioned that I am with the Medical Society Consortium on Climate and Health. We are a consortium of 58 medical societies and work with over 70 affiliated health organizations, bringing the health voice and working in coalition with other partners to bring the health voice to the climate debate for proactive climate solutions. And we are really excited that we get to collaborate with such amazing organizations. We are thrilled that we had at our high point about 180 participants. We will be sharing these resources and the slides and the webinar link with everybody who registered for this event. And we look forward to working with you and your organizations to make sure that we can do everything in our power to make sure that the OSHA standard meets the needs of workers in our communities. And with that, I think we have about 2 minutes left, but I will thank everybody for joining us. And please engage. And if everybody on this call reached out to 5 to 10 individuals and one urged them to take their civic responsibility and get friends and themselves out to the polls, that would be amazing. And secondly, if we can encourage everyone to reach out to 5 to 10 friends and ask them to send their comments in, that will make the world of difference. So thank you very much, and have a great rest of the day.